Hello, welcome to our little BIPAP lesson for today. So today we're going to talk about BIPAP and how to use it effectively in an emergency or in an intensive care unit setting. So this is going to be geared towards those that are already using BIPAP in the field on their patients, or those that are learning about how to use BIPAP, such as students or people that are going into the field. So some of these terms might be new to you and some of them might be familiar, but either way, it'd be a good little review or introduction. So BiPAP is also known as non-invasive positive pressure ventilation, or simply non-invasive ventilation. So that's how sometimes you'll see the orders come through as non-invasive ventilation. And they won't use the word BiPAP per se in orders or other contexts, but that's what they mean, and it's the same thing. So we use them interchangeably, basically. But if we're talking to somebody in the field, we'll just say, "Hey, put them on a BiPAP," right? So the settings for BiPAP are going to be somewhat similar to a ventilator, but very different from a ventilator. This is in non-invasive form using a mask or some other interface with the patient that the patient can remove, or you can remove for the patient easily and quickly should they need to have it removed for whatever reason or for convenience. But it is a way to help ventilate a patient, and that is one of the key terms to remember, that it helps with ventilation. And this is opposed to like CPAP, which is a different type of respiratory assistance, but uses one pressure level. BiPAP uses bi-level, or two levels of pressure, one during inspiration, one during exhalation, and can help with ventilation, hence the V in the NIPPV or NIV, ventilation assistance. So settings, once again, are going to be the inspiratory positive airway pressure, IPAP for short, and then the EPAP, which is expiratory positive airway, can't talk and type at the same time, EPAP. So those are your basic settings, and then you're going to have a rate or a backup rate. Sometimes I'll call it BUR or just RR as a set. And then you're going to have an FiO2 setting, or oxygenation or fraction of inspired oxygen setting. So those are your basic settings for BiPAP. A lot of times the orders coming through will specify what pressures to use. Sometimes they will be generic and just say place patient on BiPAP for tolerance. And so if it's a very generic type of order, you want to make sure that the patient is going to both oxygenate with your EPAP and FiO2 settings, as well as ventilate with your IPAP settings, especially if ventilation is a problem. And ventilation, we're referring to their CO2 on a blood gas. So who's a good candidate for a BiPAP? Somebody struggling to breathe, that has a spontaneous respiratory drive, that needs assistance. This is a good way, non-invasively, to help them get over the hump, so we can kind of address the underlying cause of their distress. Gives us some time to work with them, and hopefully fix what's got them in respiratory distress at the moment. So IPAP, typically we're going to start somewhere in the 10 to 15 range, and this is in centimeters of water pressure for the inspiratory side. And then EPAP, generally we start around 5, give or take, centimeters of water pressure as well. That's the unit of measurement we're going to use here for these pressure settings. Respiratory rate, generally you want to set it anywhere between 10 and 20 breaths per minute. And then FiO2 is going to depend on the patient needs, but if possible, we want to keep it around 60% or less to start with, if possible. That's obviously going to depend on the patient's condition and if they need oxygenation assistance or not. So some generic settings or general settings to start with. Usually we want to start down the middle of the road, be very kind of safe. Don't get too aggressive to begin with, because if a little bit will do, then a little bit is enough. We don't want to overshoot, and we don't want to make this an unpleasant, uncomfortable experience for our patient, because if we put a mask on their face and then just crank a lot of pressure at them right from the very beginning, they're probably not going to like that feeling. Like, there's the claustrophobic feeling that they're going to get, and they might just tear it off before they even really give it a chance. And then you're kind of left without any non-invasive forms to help them with. So you usually want to start kind of generic and in the middle of the road, make it kind of easy and comfortable. And if you need to make adjustments from there, you can. And that's, obviously something that we want to have room to go up with if you start in the middle of the road, you have some room to go up in the pressures to help them ventilate more if that's needed. All right, so an example of what you might want to recommend a BiPAP for a patient that, like I said earlier, is spontaneously breathing, having trouble to breathe. Let's say it's a rapid response call. Okay. So the patient's not doing well, and the nurse or any staff member wants to get some extra set of eyes or some help with this patient. And let's say they're short of breath. We don't know exactly what's going on, but we go ahead and get a blood gas. Let's say we get a blood gas that looks something like this. So an ABG showing a pH that's not great, but also not super terrible yet either. Let's say it's like 7.29. So a little bit acidotic. Let's say we've got a PCO2 that shows, let's say 68. It's a little bit high. And then let's say their PO2 is on the low end. If they're struggling to breathe, they're probably going to be hypoxic, right? So let's say it's also in the 60s. Let's say 65. And then their bicarb, we'll say it's normal for this exercise here. It's 24. So patients in distress, rapid response is called. We do a blood gas, and this is what we find. Now, patients awake and alert, we can try them on a BiPAP. This would be a good candidate for a situation where BiPAP would be indicated. They have a respiratory acidosis, seen here, and they're also hypoxemic. So this non-invasive form of positive pressure ventilation can help this patient right now. So what we want to think about with these settings that we've got access to is how can we both approach the ventilation problem and the oxygenation problem in one go? Well, BiPAP's a good way to go, right? We've got ventilation problem should probably be our priority here. Let's fix this first. So what we want to do is we want to decrease the PaCO2. That's going to make the blood less acidotic because the CO2 in the serum is hydrogen ion that produces an acidotic state. So we want to get rid of CO2. Lowering the CO2 back to the normal range for this patient should help with that, right? They've got a normal bicarb, a normal base level. So getting rid of acid should make the blood less acidotic and shift this pH up towards the normal range, 735 or maybe even closer to 740. So we want to use the difference between these two settings to help decrease PaCO2. And there's another idea or term that they can use to describe this pressure difference. And it's not really used here, but we could think of this as pressure support. It's almost the same thing as when you use the ventilator with pressure support. It is the pressure difference between the expiratory and the inspiratory pressures. It's the support, if you will. And what the support or the difference in pressures is going to do is increase the tidal volume that the patient's breathing per breath. So if we can ventilate out CO2 by increasing the tidal volume, that is something we want to keep in mind as we go about setting up our BiPAP and placing it on the patient, is there needs to be a pressure change or difference when they inhale versus when they exhale. So a way to kind of visualize this is if we were to kind of graph this out over time and use some of these ideas for settings. Let's say 5 centimeters is our expiratory baseline pressure, right? So this is a pressure and a time scalar. We would see that this pressure level during exhalation is around 5. And then as they inhale, the pressure level is going to go up to, let's say 15 in this case. And then they're going to allow for exhalation back down to the baseline pressure. So looking at this as the inspiratory phase, and then this portion here as the expiratory phase. And one thing to note that it's kind of representative of a 1-to-2 ratio, the time frames between these two pressures, inspiration and exhalation, reflected in the IE ratio. So the difference in pressure seen here, we'll use a different color now. This is what's going to give the patient the extra boost in pressure during inhalation. And what that's going to do is help remove CO2 and help shift this pH from an acidotic state, hopefully coming up to more of a normal, closer to 7.40. That's the goal anyways. So The inspiratory positive airway pressure is a set limit. It is not a support. So to call it pressure support is a little bit misleading initially, but just to illustrate that idea, I wanted to kind of bring that up initially, right? So the inspiratory positive airway pressure is a set value. It's an absolute number, right? So if you set it to 15, it's going to go to 15 and nothing more. So the difference between the inspiratory pressure at this top end here and the expiratory pressure, the baseline pressure, EPAP, that will be the change in pressure, or delta P. That's actually the better way to call that. Pressure support, no. Delta P, yes. Change in pressure, right? So we've got pressure change of 10 centimeters of water when the IPAP is 15 and the EPAP is 5. The difference there is 10 centimeters of water pressure. Generally speaking, that's enough to help a lot of patients in a lot of situations to augment or boost their tidal volume. Boosting the tidal volume, getting more air in per breath, is going to help with their ventilation status and decrease CO2 and help to normalize the pH, hopefully all the way to normal. So the delta P, or change in pressure, is something you want to keep in mind, especially if changes need to take place with the BiPAP settings. All right, so if we start at an EPAP of 5, that's a pretty bland generic setting. The baseline pressure in the lungs at 5 centimeters of water might help slightly with our PO2. Okay, might not though. We might need to make some changes to increase the oxygenation status, but we're going to try to dial in the PCO2 and the pH first. Right? But let's say down the road, an hour later, they're tolerating well. Time goes by, they're doing okay, except for that their SATs are still on the low side, and we've had to boost up the FiO2. So, perhaps we do another blood gas shortly after placing them on the BiPAP. 30 minutes to an hour later, we do a blood gas, and let's say we've got some new values to work with. Let's use, I guess we'd go with the orange. Okay, so here's the new ABG. A little bit later, patient's ventilating much better. We'll say they're like 733, PCO2's come down. Let's say it's now closer to normal range, but still a little bit high. Let's say it's like 49. Okay, improvement, yes. Perfect, no, but tolerable, yeah. Okay, and let's say that their PO2 hasn't changed too much, even though they're on a higher FiO2 perhaps, and their EPAP isn't terrible, or it's not super high yet, but let's say their PO2 is still slightly hypoxemic, right? Let's say we've gone up to like only 70 for the PO2. Bicarb obviously going to be the same, 24. Okay, so if they're still hypoxemic, this is another life function we want to address, right? Oxygenation. Now, 70 is not terrible for somebody who's in an ICU. We're not going to really bat an eyelash at this. This is compatible with life. But if this was a test question that we were taking, we want to maximize and optimize our settings as much as possible. We could actually still have some room here with the CO2 and the pH. But let's say that it's a mix of real world and test questions, and we want to try to find a way to optimize this patient's oxygenation now that we've, done a lot to fix their acidosis. So next, let's approach this oxygenation problem. All right, one way we can do this is increasing the FiO2, and let's say that we've already gone past the 60%. We're at 75 or 80%, and they're still mildly hypoxemic. Maybe their SATs are cruising around 90, but doc says, hey, let's try to get this PO2 up and the SATs up a little bit, closer to 92. Okay, what can we recommend now? Rather than just throwing more oxygen molecules at them, this isn't quite as effective. We can tell if we get above 60%, they're still hypoxemic. We need to change the dynamic of how the airflow is going into and out of the lungs. And one way we can really help with changing the dynamics of the airflow in and out of the lungs, especially from an oxygenation standpoint, is to increase the expiratory positive airway pressure, the EPAP. This is the same concept of raising the PEEP on a ventilator. When you raise the baseline pressure in the lungs, the EPAP happens during the expiratory phase. And if you increase the level of pressure during the exhalation phase, you're going to increase the mean airway pressure. So increasing EPAP increases mean airway pressure. And increasing mean airway pressure drives oxygenation. Another way you can think about this is it also increases the FRC. That's another concept that some of the test questions will reference. So increasing EPAP, same thing as PEEP or CPAP. Increasing the expiratory positive airway pressure increases the mean airway pressure, increases the FRC, and increases the PO2. So that's kind of a chain you can follow in your mind, I guess. Now, when you increase the expiratory positive airway pressure, you are increasing the baseline pressure level seen by the alveoli and the airways and the lung tissues for essentially a longer time interval during the inspiratory and expiratory phase. That's what makes EPAP and PEEP and CPAP pressure changes very effective to drive oxygenation. You're typically in normal ventilation modes, a ratio of 1 to 2, increasing the baseline pressure for twice as long during the inspiratory cycle. If you looked at this as a 1 to 2 ratio, typical breathing pattern 1 to 2, increase the 2 side, the expiratory side, and you're bringing up the average pressures much more than you would by increasing the 1 side or the inspiratory side. So that's one way that you can kind of keep that straight. Like, how does this affect the pressures in the lungs, and how does this average pressure, right, mean is average airway pressures, affected more by PEEP and driving oxygenation? Well, you're affecting the pressures in the lung for more of the exhalation, or more of the inspiratory and expiratory cycle, the respiratory cycle. The exhalation phase happens for twice as long as the inspiratory phase. It's a good way to kind of keep that straight and remember that. Now, let's say based on this blood gas, we get a recommendation or an order. Let's say we make a recommendation and we get the order to increase the EPAP. And let's say that the physician orders for this EPAP to go from 5 up to 8. That's a small change, but it might be enough in the right direction. So we'll come through and we'll go ahead and change this EPAP level to 8. Let me move this out of the way, actually. Make some room. So previously our delta P was 10. And now we come through and say, okay, doc says change this to 8. So the respiratory therapist will make the change and come in and say, all right, our EPAP is now going to be 8, but our IPAP didn't change. So it's still going to be 15 during inhalation and then drop down to the new setting of 8. All right, so we have 15 on the inspiratory, and then we have 8 on the expiratory. Now, what was the change in pressure now? 15 minus 8, delta P is only 7. Change in pressure is now only 7 centimeters of water. So our tidal volume is going to be less than it previously was at these new settings. So by making a change to one setting, the EPAP, and not taking into account that the IPAP is an absolute number, not a relative number, the change in pressure now is only 7 centimeters of water pressure, whereas it was 10 before, and giving us a good ventilation status. So what's the net result here? Is that we might see our PO2 increase and think, okay, awesome, we fixed the oxygenation issue. But if we're not careful and paying attention to our settings and the difference between the two, we could cause this blood gas to shift now towards the acidotic state again. Let's say we're back at where we started. And we're thinking, what happened? Our PO2 went up. How come our ventilation status worsened? Our delta P did not remain the same. It changed, so our ventilation changed. So we might be happy with the PO2 and think, yeah, it's good. But now we're retaining CO2 and now we're acidotic again. Oops. So when you're making changes to the EPAP to improve oxygenation, it is very important that you take into account that the pressure change or difference between the two, if ventilation status is good, needs to be maintained. So when you get an order to increase the EPAP, you want to make sure that your ventilation status isn't going to suffer because of that change. And if it might, and let's assume that the ventilation status is or was good, you're going to also need to increase the IPAP to accommodate for the potential decrease in the change in pressure. So you'll need to do both if that's the case. Increase both pressures to maintain the same delta P or pressure support, however you want to think about it. Delta P is better, I think, to think about it that way, the change in pressure. So change both so that the delta P stays the same. So what would that look like then? Well, if the EPAP needs to go to 8, then the IPAP needs to go 10 more than that. 18. That will keep the same change in pressure that you had previously, 10 centimeters of water pressure, that gave you a good ventilation status. So that is something to keep in mind when recommending changes or making setting changes. Take into account that the IPAP and EPAP are absolute pressure level settings. They are not relative to each other. They're independent from each other. So that's all we've got for today. So thank you, and tune in next time for the next lesson. Let me know if you have any questions or comments down below.